Good morning. Today we welcome Mike Friedrichs, who is a chronic disease epidemiologist for the Utah Department of Health. Today he will help us understand the role of area level um, deprivation reinforcing COVID-19 inequities. He will highlight social determinants of health impacting disease outcome. Let us welcome Mike Friedrichs. Good morning, Michael.
Good morning. Thank you for having me.
It must be fulfilling to do your job to stay there for more than 30 years.
Public health is a great career, and I would encourage anyone to go into it. You work with the best possible people ever.
Yeah.
I wouldn't have traded it for all the money I could have made elsewhere.
I am so excited to hear your views in terms of talking about inequities in health and how we could um, design resources to impact public health outcomes. And it would be nice to also help us understand what enhanced mitigation strategies we could do to face or coexist with COVID-19. So tell us first and help us understand, what is an epidemiologist?
Uh, we're the people that just keep track of diseases. We study disease rates, risk factors, behaviors that contribute to disease. Basically, we're the data people in health departments.
So you're telling us you are probably the detectives, right?
That's right.
So, having said that, I would like to understand more about the research that you had conducted with the Department of Health in terms of looking at area level um, uh, deprivation, and help us understand what is that and how does it impact the ethnic and racial and workplace-based inequities in Utah.
We're fortunate in Utah in that we've carved our state up into what we call small areas, 99 small areas. And for each of these, we've looked at an assortment of factors, poverty, income, education, household composition, employment, and developed a scale that ranks these communities from the most affluent or wealthy communities to the areas most in need of interventions to achieve health equity. And of course, we've seen huge associations with chronic diseases like hypertension, diabetes, addictive and abusive substances. Tobacco rates are much higher in the more deprived areas. There's differences in infant mortality and life expectancy. So we've known about those kinds of diseases and how they associate with area deprivation for a while. We've been doing this work for probably 10 years or so.
That is so interesting. I myself, I'm involved in chronic disease management and looking at communities in the Philippines where we have a medical mobile clinic and telemedicine to actually follow them on a more sustained fashion compared to what we used to do with doing just medical missions, like US-based medical missions going to the Philippines and other areas. And we had realized that medical missions were plainly like band-aid approach to chronic disease management, and a more continuity and follow-up is a lot, are a lot better strategies to mitigate the impact of chronic diseases. Taking you back to COVID-19, take us where what you did in terms of the research study, and would your results extrapolate with other areas globally or even in the United States?
Yeah, we were fortunate to have this infrastructure in place where we had this index where we looked at the community deprivation levels, and we had seen some association before in about 2009 when we had the H1N1 flu. We saw that it disproportionately affected those communities. We didn't have the health improvement index, as we call it, in place, excuse me, at that time, but we still saw that areas that we knew had higher rates of poverty had more infection with H1N1. And we recently did a short paper on Legionella disease and found that, again, it was more prominent in areas with higher deprivation. So when COVID-19 hit, we had this infrastructure in place and we tracked it weekly with our health improvement index. It started in Park City, Utah, which is famous for the Sundance Film Festival and skiing and where really affluent people live. But within 4 to 6 weeks, it had moved to where by far the highest case rates were in the more deprived communities that were servicing the folks in Park City.
I see. I see. We are noticing even here in California, COVID-19 incidence is attached to uh, uh, different area codes, and the area codes are basically linked with people with lower socioeconomic status. So tell us more about poverty, income level as determinants for the outcome for COVID-19.
Well, I mean, I guess, the question is, why are these communities, why do they have more spread? And we looked at census data, and these communities have much higher rates of the kinds of employment that can't be done remotely. They are unable to telework because they're in, industries like food preparation, construction, transportation, those kinds of things. And they're over 6 times more likely to live in crowded housing where people have more people than they have rooms in their home. So there's really, it's difficult or impossible for people that are exposed or infected to isolate or quarantine themselves. So it's not that being poor makes you more likely to get sick. It's that the conditions in which you live as a result of your socioeconomic status put you at higher risk.
I understand. I understand. So in terms of like the implication of your research study in terms of designing public health strategies, what would you recommend for us to mitigate the spread of COVID-19?
Well, there's the short-term strategies, which we need to increase testing. We need to work on better options for isolation and quarantine. We need to work with clinics and especially businesses in those areas to make sure they have policies that allow sick workers to stay home. And in public health, we need to do things like make sure we have culturally appropriate messaging or language appropriate messaging in place before it moves to those communities, right? We tended to react after it hit those communities, which have high populations of Hispanic persons, and then we translate everything into Spanish. And we know these diseases will move to those communities quickly. We should be out in front of that, and I think that's a lesson learned for us, and we hope to carry that forward in the future. In the long run, and the difficult part of social determinants of health is it is a long run. And in the long run, the answer is to work on the reasons why those communities have a health disparity in the first place, so that we work on things like affordable housing, food insecurity, minimum wages, things that will improve everyone's living conditions so they aren't living in places that puts them in higher risk in the first place.
I understand. I mean, I myself, this is such an eye-opening experience. We were doing some studies and QI projects at Stanford, and um, after 2 weeks of mobilizing that initiative, we realized that we have to change everything to Spanish and translate everything, all the resources, the survey, instructions. So we're behind. So I understand. I think I agree with you that we should be more forward thinking in terms of strategies to not only um, enhance or mitigate all this public health um, um, some public health initiatives, but also, be a little bit more forward thinking or out of the box thinkers in terms of possible solutions and translation of what we know to actual solutions to their problems. So I would like to, we are on our 20-minute um, line here. I would like to ask you, in terms of a message to our listeners, what would that be from you?
That I think that we all need to work towards health equity. It's not just a function of the health department or the government. Communities need to come together. We need, as a people, we need to make that a priority, that everyone has an equal chance to be successful and healthy. And I think that communities, schools, faith-based organizations, they all play a role in that, right? We need to work together as a people and decide that we're really only as good as the least of us, and that we can be better. We can do better.
Thank you so much, Mike, for your message. And I really want to thank you so much for participating on our very first episode for the podcast for Medicine for Good. Um, and more power to you in terms of helping us mitigate chronic diseases and acute diseases, and especially now with the transmission and spread of COVID-19. Appreciate your input. Thank
Yeah,
you.
thank you for having me. Wear your masks, stay home if you're sick, and wash your hands. Thanks so much.
Thank you. Bye bye.
Bye.